We now move on to the competitions. The poster competition is already on its way. We have our judges, our jury members, Sharmista Nai ma'am, DGM Nursing, KD Hospital, President Gujarat Chapter, Annie, Ma'am Upama De, Professor cum Principal, College of Nursing, Tata Main Hospital, Jamshedpur, President Jharkhand Chapter, Annie, and Professor Dr. Simple Rajgopal, Principal, Sri Narayana College of Nursing, Ernakulam, Member, Kerala Chapter, Annie. A huge round of applause for them.
We now move on to the next segment of the ANEI competitions, a platform that celebrates innovation, leadership, and excellence in nursing practice. To evaluate today's competition categories, may I invite our esteemed jury members, Dr. Falakshi Manjrekar, Director Nursing, PD Hinduja Hospital and Medical Research Center, Mumbai, and Member ANEI. Madam, please come on the dais. I would also like to invite the second jury member, Dr. Rita Lakhani ma'am, Managing Editor Nursing, JP Brothers, Medical Publishers and Member ANEI. We welcome you ma'am. And we would also like to welcome Major Anjana Williams ma'am, Group Director Nursing Services, Ruby Hall Clinic, Pune and Member ANEI. Please give them all a huge round of applause. So we begin with the first competition, Future Nurse Engagement Challenge. It is now my privilege to invite our first finalist, Ms. Dolly Bishwas, Chief Nursing Officer, Fortis Hospital, Anandpur, Kolkata, and National Secretary, ANEI.
Good morning once again to everyone. I know that very engaging session and mind-blowing conference that we are presenting, that we are attending since yesterday. And I give kudos to entire Maharashtra team who has organized such a fantastic way this conference, and give a big hand to Maharashtra team, entire team. Thank you, Dr. Elizabeth Joseph and her team for organizing such a mindful event. Thanks to all the juries over here sitting, Dr. Rita, Madam Falakshi, Madam Ranjana Williams. Thank you for your time. So let me take you through my quality improvement projects. So we know that since yesterday we are listening to our students, our very young advanced beginner nurses and novice students, that how much important it is to handhold the student at the clinical field, nurturing them, guiding them, and giving them, an empathetic way of handling, or giving them a confidence at the clinical field is very, very important. And sometimes we lack with that. So here is the project, the session, Strengthening Clinical Competency Through Hospital College Clinical Partnership Model, a collaborative learning approach for nursing students. As we know that when a clinical training is just getting over, or a student nurse is just entering into the collegiate education from the first year of nursing, it is, from a theoretical background or from a demo lab, shifting to the actual clinical field, giving a cultural shock to them. And there the seniors needs to handhold them and cajole them or train them adequately. And if there is any lacking been found, then only the student nurse feels very, tensed, and they are not able to accept the nursing truly nursing from their mind. So here it is written over here that clinical training is crucial component of nursing education, and bridging theoretical knowledge and practical training is important. However, many students face challenges in translating classroom learning into the clinical practice due to limited structured mentorship program. So keeping in mind that we have done a baseline studies, because being a corporate hospital, we do not have our college, but we engage the college, other colleges, those who are not having a hospital, to engage them to our clinical practice, where the clinical baseline data says 61% of clinical competency they are having, limited confidence, which in the Likert scale shows 3 on all the points out of 5, and inadequate participation in the patient initiative activity, where it scored 27%. And primarily due to this absence of structured training system and weak collaborations between hospital and nursing college necessitate the comprehensive clinical partnership model. And there we go. Therefore, a hospital-college clinical partnership model was developed to enhance the collaborations between healthcare institution and nursing college. The model focuses on structured mentorship, competency-based training, and active students' participations. So our aim was to strengthen the clinical learning competency and development among nursing students through a structured hospital-college partnership model. And our objective framed as to improve the nursing students' clinical competency and confidence in patient care. Number two, to establish the structured mentorship between student nurse and the staff nurse and the nursing students, and to involve nursing students in quality improvement and patient safety initiative, and to enhance the collaboration between hospital staff and nursing college faculty for better clinical educations. We have seen that if a student nurse who has come to us to get the exposure, if a staff who is not hand-holding the student or not helping them to learn them how to check even a simple blood pressure, like tying the cup at 3 finger above the antecubital fossa, and then raising the pressure and feeling the pulse first. Radial pulse must disappear. You put the stethoscope and then you start raising the pressure again, at least 20 mm of Hg, where the pulse get disappear, and then you start receiving the coroscope sound by releasing the pressure. The first coroscope says that it's systolic and the last disappearing sound is diastolic. These minute observations, if a staff or a clinical instructor or a tutor is not teaching the student will be unlearned throughout the life. So that is why it is very, very important to make the student to learn how is this actual observations required at the clinical field. If a staff nurse doesn't know antithyroid or a thyroid medications not to be given along with an proton pump inhibitor, what is the rationale? What is the reason? If our experienced staff is not saying, the student or the staff will never be able to know, because the efficacy of the drug, the action of the drug get completely diminished if it's given with the proton pump inhibitor. If a student nurse never heard about the bubblegum sound of the abdomen, the student will not be realized when to give a sips of water to a patient, only will be relying on the doctor's note, not on the own experience that bubblegum sound is important before starting a sips of water for a post-operative patient who is anesthetized. And there the mentorship comes, and every staff nurse or a senior nurse must understand how much it is important for a student nurse to help to learn all this nitty-gritty, which Dr. Narayani said yesterday, a nitty-gritty to be looked into by the senior nurse in the clinical facility or the clinical field. Simultaneously, when our third year novice student yesterday was lecturing and saying, our patient loved us very much. Why? Because when a bell rings, and we first, the student would run to a patient's side and ask them, sir, do you need anything? You see, so when a student runs, because she is new to the area, and she is having motivation to learn, we need to uplift that motivation. We need to support them. So here we go. The project type was educational innovation project, bridging the theoretical knowledge to clinical practice. Setting, tertiary care hospital, Fortis, affiliated with the nursing college, Sister Florence Nursing College of Kolkata, who is not having a hospital, and the Tripura Institute of Nursing Student. Participation, student nurse 60, fourth year, and the 60 clinical mentor. Who are these mentors? These are none but our staff nurses. So we have 20 wards, 20 different wards, a respiratory ward, a cardiac ward, a general ward, many, private ward. So like that 20 wards, we have given three nurses to each, posted with 6 or 5 allocation for a 5 twin rooms, and with each student given each staff given one student to play the mentorship role. Along with that, college faculty members were around the clock there. Duration of 6 months. Data collection tool, we have used clinical knowledge questionnaire, clinical competency checklist, clinical attitude monitoring checklist, clinical confidence assessment like a scale, student feedback questionnaire, mentorship evaluation form, and patient safety participation record. Here we go with the intervention. Structured clinical orientation program is given to on basic hand hygiene, infection control practices, basic patient care. Clinical mentorship program, which comprises student assigned to a instructor, the clinical mentor, those were the staff nurse, and mentor provide bedside guidance and supervision for each procedure that the staff nurse performs and given the guidance to the student. And skill development session also done, weekly clinical skill demonstration. We have a very good high fidelity mannequin simulation lab. So there also we have given opportunity for the student to practice, and then simulation training and case discussion also done with the students. Student participation in quality initiative, which were lacking. So we motivated them to participate into the infection control week, in patient safety week, as well as in hand hygiene week, and fall prevention monitoring program, and 5 mandates of medication administration program. Monthly academic clinical review done jointly with the student and their clinical tutor and clinical instructor. What was the result? Improved clinical skill performance among the nursing students that we have started seeing, and better integration of theory and practical clinical care, because each rationally been explained to them why you are doing, how you are doing, increase awareness of patient safety, stronger collaboration. These are the, every orange color bar which is showing that how much percentage has improved from their baseline data on patient care, patient safety, infection control, hygiene, clinical attitudes. Everything is depicted in this graph which you can see over here, and every moment, even the roster planning, how it will be there with the staff nurse and the student, that was being taken care by the in charges. And these are the attitude also been measured with the clinical graph which you are seeing. The orange bar is showing that there is an enhancement of the students' knowledge from 61% to 84%. So discussions here, not only the knowledge, the clinical practice which has improved, where we have seen the 23% of clinical practice has improved, 24% of attitude has been improved, and then we have developed that, concluded that this kind of mentorship program where one staff nurse will get one student and handholds them and train them each and every procedure, and the knowledge which needs to be learned to them, encourage them, motivate them to practice at the clinical field and attains all kind of safety program. That's the sustainable model and the way forward that is been narrated. Scale up the model, not only with the 4th year, but with each and every year students. Right from the 2nd year, 3rd year, 4th year, if we can practice this model, student will learn. Strengthening the mentorship program is our motto, and to sustain it, simulation-based learning labs to be used full-fledged, giving the opportunity not to lock the lab, but let the student learn. But yes, our clinical instructor also has to help them out, and continuous evaluation feedback taken, and sustainability also measured. I think the last slide is not been, something is wrong. Anyway, that's the end of my slide. So thank you very much for your patience hearing. There we go. I must tell the staff nurses, a lot of college instructors are sitting here, quality nurse, in charges, senior nurse, chief of nursing, deputy nursing. Please give the opportunity for the students to learn and grow and flourish, to take our profession to an highest level. That is what we want to see, and that is the future nursing. Thank you very much.
Thank you, Dolly ma'am, for your presentation. Our next finalist is Professor Delphina Mahesh Gurav, Vice Principal cum IQAC Coordinator, SMES, Srimati Sunanda Praveen Gambhirchand Institute of Nursing and Paramedical Science, Mumbai. May I invite Madam Delphina to deliver her presentation.
Thank you so much, ma'am. Namaskar, Mumbai. Namaskar. Okay. So here, I must say that all of us seated here at some point of time have lived the journey of a novice nurse. The transition from being a student to staff nurse is at most difficult, however knowledgeable you must be. I must say that we do go through a fear, apprehension, and the fear of unknown. What is it going to be? Whatever we have learned in our college life, it is entirely different when we step into the field of clinicals. And there we thought of, bridging the gap between the classroom to the clinical practice. We at Seva Mandal Education Society, although the idea was conceptualized by me, I had a team of a very able principal, Madam Shilpa Shettigar, Namrata Choprekar as the then HOD of the department, and Ms. Sonam Gupta as the coordinator who helped us implement this project. So here I am presenting our idea. Although it is a very small project, but we thought that it is definitely a very, very helpful project that is sustainable and practical to deal with. So here I begin with my project. There we go. So respected dignitaries and my dear colleagues, here am I presenting the topic Closing Classroom to Clinical Gap through Alumni-Led Clinical Teaching Cell. So the background, the need that we felt, as I just mentioned, that the transition from clinical learning to real-world clinical practice remains a significant challenge for all the nursing students, often resulting in reduced confidence, skill gaps, and difficulty in clinical decision-making. And definitely, this is a threat to the patient safety. So students primarily in the college acquire the theory-based knowledge from the textbooks. However, the science changes every day, and as we know that real-time data keeps on changing, which takes time to come into the textbooks. So how do we bridge this gap? Whatever is new and yet not in the textbooks. So you will find that definitely there's a significant gap which exists between this static learning and the rapidly evolving technology-driven and patient-centered trends in the contemporary healthcare. So leading to challenges in real-time clinical application. Whereas, why did we tap the alumni group? Because alumni bring practical insights, updated clinical practices, and contextual problem-solving abilities in the real-time scenarios. So we thought of integrating alumni-led clinical sessions into the curriculum, and through the exposures that, the real-time exposure that the alumni have, we thought that they could be tapped and utilized to actually teach the students, what are the in-between things that they should learn in the clinical practice. So this initiative aims to bridge the gap by engaging the alumni who are practicing nurses as clinical educators and mentors. This approach strengthens the academic clinical integration, promotes experiential learning, and also nurtures a culture of mentorship within the institution. So the aim was to enhance the clinical competency and readiness of nursing students by integrating them both, and the specific objective was to bridge the gap between theoretical knowledge and the clinical application, to familiarize the student with current hospital protocols and practices, to build confidence and reduce anxiety among students during their clinical postings, and to promote professionalism, socialization, and mentorship through alumni interaction. So we had taken a cozy experimental educational interventional project, and undergraduate 200 students were our samples, and we had excluded the students who were absent during these sessions. The findings that we came across, it demonstrated a marked improvement in knowledge, skills, professional competences among the nursing students following the alumni-led clinical teaching. Across all domains, post-test scores were consistently higher than the pre-test scores, indicating the effectiveness of the program. And the overall interpretation showed that it resulted in a positive shift in all the learning domains. The highest improvements were seen in ICU management and emergency care, which are typically difficult to grasp. The findings confirm that experiential alumni-led clinical teaching enhances the cognitive, the psychomotor, and the affective domains. The program effectively reduces the gap between theory and clinical, making students more competent. And the most satisfactory outcome of this project that we came across is enhanced visibility of the students, their efficiency compared to the novices that were admitted and enrolled in that particular parent hospital of ours. And we would get the feedback from the consultants, the senior nurses, about our students being outstanding, even than the novices, the new enrolled nurses. So the areas that we projected, there were many areas, but I have only projected the very important ones. So we thought of cath lab responsibilities, ICU management, nurses' role in emergency, professionalism. In professionalism, there were various domains that were taken care, how to deal with patients' relatives, how to deal with patients, how to, in between whatever communication is required in the hospital. Those domains, quality indicators, oncology, advanced care. So you could see that all the domains, the pre-test and the post-test, there's a vast difference that was seen. Also the feedback from the learners showed that they want these sessions to happen on a regular basis. And not only that, the clinical narrative that the reflections that were received from the healthcare experts on this alumni-led clinical teaching showed that every aspect, whatever we had dealt, actually ranged above 4.52 out of 5. So here I conclude that this study highlights the effectiveness of alumni-led clinical teaching as an innovative strategy to bridge the gap between the theoretical knowledge and the clinical practice. It's the key finding shows a significant improvement in clinical competence and confidence in their students. Unlike traditional classroom, alumni bring contextual real-time clinical exposure, making learning more relevant and application-based. And I must proudly say that all those alumni who have actually been out from our students have lived the life of the student and also the transitional life from being a staff nurse from the student. And therefore, they were the right tapping, resource, which we thought that they could give the right examples, how they felt from being student to getting into the staff nurse position. And what is the gap actually? So these small things are very, very necessary, which we felt would make them confident enough. And believe me that when we took the first competency assessment of our students, after placing them in the clinicals, the stakeholders' response, the senior nurses' response, and the students' response itself was so overwhelming for us that definitely there was, that fear was gone, the apprehension was gone. And the students felt that, yes, they know how to deal with all this situation. So we feel that definitely this study has a significant relevance in enhancement of clinical decision-making skills, better visibility of the students, efficiency compared to the novices which are enrolled. So the way forward, so these are some of the glimpses, the alumni who proudly want to get back to us with their clinical competence, the thing that they have not learned in the college and now that they are doing, they want to share with us. So because an alumni group we shared, it had a ripple effect, and now more students, more alumni want to bring their knowledge back to the college, and that's how we are bridging the gap. So the last concluding slide, that is the way forward. We want to escalate this practice to make it institutionalized model, capacity building of the alumni, development of standard teaching protocols, strengthening simulation-based learning, use of digital platforms, and strengthening the alumni engagement. So I thank ANEI for giving me this confidence and the opportunity to present a small but the real-time project in front of you all. Thank you so much.
Thank you, Ms. Delphina, ma'am, for your presentation. We shall now move to the Nursing Operational Efficiency Challenge, the second competition under ANEI competitions. And kindly note, the jury on the dais will also be judging this set of competition. It is now my privilege to invite our first finalist, Ms. Poonam Talreja, Chief of Nursing Services, HCG, Astha Cancer Center, Ahmedabad. We welcome you, ma'am.
Good morning, all. I would like to thank Annie for giving me this opportunity. My study was on daycare unit. I am working in oncology units, and I have challenges to start a pre-medication before pre-medication in the chemotherapy patients. So there were so many challenges we found out, and at the end, what happened, chemotherapy daycare, patient came and taken chemotherapy, and they have 4 hours or 6 hours cycle. But because of the operational challenges, there may be a delay in starting of pre-medication, and it results for the discharge delay and results the patient dissatisfaction. So my study was to assess the effectiveness of focus intervention to initiate pre-medication administration among patients admitted in daycare, thus by reducing the turnaround time from admission to first contact intervention. Because my aim was to reduce the turnaround time for initiate the pre-medication of chemotherapy patient. The aim to study an evaluation of the effectiveness of focus intervention in facilitating timely initiation of pre-medication and reducing the turnaround time. The objectives are to analyze the contributory factors, policy deviation to intimate the chemotherapy drug administration, to assess the existing practice of initiating a pre-chemotherapy drug administration, and to develop the focus intervention on the contributory factors to achieve 30 minutes of turnaround time. To evaluate the effectiveness of focus intervention, focus intervention on initiating the pre-medication administration, and to compare and contrast the satisfaction score of patient and nurses on focus intervention. Because of the delay in pre-medication, there will be a dissatisfaction in patient as well as in the nursing. We take the study in chemotherapy daycare unit, and our population is who admitted in the daycare chemotherapy department, and our sample size was 150 and duration was 6 months. The sampling technique was purposive sampling, and data collection through the self-structure checklist and related for the chemotherapy medication administration. Data collection, we use direct observation, and patient and nurse satisfaction survey will be done using Likert scale. We use this structure checklist for the data collection. In that, we include patients are scheduled appropriately, because we found that patients are not scheduled properly. All patients come together. So these are the checklist point. Pre-chemotherapy assessment was done or not, because it is a mandatory requirement before chemotherapy. It should be assessed by the nurse as well as by the medical officer. Doctors review and approved for the pre-medication order written given or not. Pre-medication are ordered and indented by the nursing on time or not. Stock levels of essential pre-medications are available in the department or not. And pre-medications are administered within the recommended time frame. And communication among doctors, nursing, pharmacy staff regarding the pre-chemotherapy drug is clearly and timely, because we came to know that starting of pre-medication, there is an involvement of nursing medical officer, pharmacy, and consultant. So these are our satisfaction survey point that patients, for the nurses, that patients are coming in within 5 minutes because nurses have get time for the initiation, assessment, vital taking, IV cannulation. So minimum gap should be there. If all patients come together, then 1 or 2 nurse or 3 nurse can't take all the things together. So patient registration assisted on time or not, pre-chemotherapy assessment done, and dedicated resources are available. Pre-medication kits received from the pharmacy and use the substore efficiently. For the patient satisfaction survey, we use the head patient guided properly, head patient had guided that you have to come on this time, and was your waiting time is reasonable or not. Doctor explained the procedure properly, or the concern was addressed or not, and the pre-medication is informed to you, is it started on time, and the satisfaction level of the patient. These are the inclusion criteria. We included all patients who came in daycare chemotherapy and who are willing, and exclusion criteria for all other areas exception for IP patients and who are not willing. We did this study in a 3-phase, like we collect pre-data collection and survey satisfaction from 1st January to 28th February. Then we implemented the focus intervention and analyzed the pre-data and patient satisfaction from nurses and doctors and patients from 15th March to 15th April. And after post-collection data, we take from 16th April to 31st May. And in last phase, analysis of post data and patient satisfaction and nursing satisfaction from 1st June to 15th June. These are the root cause for delay in pre-medication starting, that improper scheduling of patient by operation staff, delay in patient pre-assessment by doctor and indenting by the nurses, lack of defined workflow, unclear communication between nurse, doctor and pharmacy team, material unavailability of the proper stock of pre-medication. There is a lacking of computer. That's why the nurses have a delay for the indenting, and the environment high patient flow, because all daycare patients came in morning shift. These are the pre-intervention analysis. It shows that all the factors, like I mentioned earlier, that it is assessed earlier or not, pre-medication are available or not, indent on proper time. So it shows that all the data are below the 70%. We start the standardized pre-medication workflow. In that, the turnaround time checkpoints were made, the patient arrival time, doctor assessment time, drug indent time, pharmacy dispatch time, and the pre-medication administration time. Refine the process based on learning, that predefined allocation of patient, that operation staff are included in that they have to schedule the patient, and before the admission, they have communicate with patient for the admission of the patient for admission within the gap of 5 minutes. Increase the substore for 4 patients, and pharmacy department extended their support by providing a 15 sets of pre-medication each day to ensure the adherence to turnaround time. And one more computer added to maintain the indenting on time, and medication indenting training given. Dedicated staff for indenting, there is a medication nurse is there, so she is cross-verifying before dispatching from the pharmacy, and monitor the daily feedback from patient as well as from the nurse. These are the results after starting our all aspects, that we increased from 95, the patient is scheduled 95% properly. Assessment was done on time, 97%. Doctor's review, 96%. Pre-medication indented on time, 96%. And medications are dispatched by pharmacy team is 95%. Stock efficiency is 95%. And our pre-medication chemotherapy in start 97%. These are the data from the patient satisfaction survey. As you can see, that pre-data, the disagree level and the strongly disagree level was high, but in the post-intervention, my patients strong agree was very high. So patients were satisfied because treatment start on time, patient discharge on time, so they were very satisfied with that. These are the nursing satisfaction because, as I mentioned earlier, because of the delay, the questions were raised to the nursing only. But because of this study, we have came out that there is no issue only for nurses. There are so many challenges for overcome to this turnaround time. So because of that, our nurses were also dissatisfied. But after the study, because everyone is in a one line and we can reach the turnaround time within 30 minutes, so our nurses are very satisfied for this workflow. These are our time that from 40 minutes we came to the 16 minutes in August. And overall, average time, when we start the study, it was a 1 hour 11 minutes, and at the end of the study, we reached average time is 23 minutes. The present study demonstrates that the significant reduction of the average turnaround time, medication administration from 1 hour 11 minutes to the 23 minutes, from the operational perspective, the intervention improved staff efficiency by reducing the delays, clarifying roles, and standardize the procedures. The likely decrease the work-related stress and improve the task prioritization. Furthermore, shorter waiting times and smoother processes contributing the higher patient satisfaction as patient experience more timely care and reduce anxiety with delays. Yes, 1 minute. So this is the way forward, the strengthening the digital tracking, strengthen the multidisciplinary team involvement, benchmark for national and international standards, and patient education for pre-visit preparation and PDCA cycles. These are our reference. Thank you for attention.
Thank you, Ms. Poonam ma'am, for your presentation. Our next finalist is Ms. B. Mahalakshmi, Chief Nursing Officer, KMC Specialty Hospital, Tamil Nadu, and Vice President, Tamil Nadu and Puducherry Chapter, ANEI. May I invite B. Mahalakshmi ma'am to deliver her presentation.
Very good morning to one and all gathered here. So I will not take much time. I'll keep up the time. My presentation is about how to enhance the nursing operational efficiency with standardizing the workflow for the nurses and smart automation. So every time we used to say saving time for the nurses definitely will improve the patient's direct patient care. So we have to reduce the unnecessary time delay for the services. Thereby we can improve the operational efficiency. The problem what we have identified, there are a lot of delays happening in the day-to-day activities in the patient care settings. So we have identified the most important 3 problems. So those are, the first thing is the problem which is significant time delays because of the routine clinical activities due to non-standardized processes, manual monitoring requirements, and inefficient coordination during the doctor rounds. These are the major problems we have identified. So we'll see one by one. So during the rounds, almost the doctors, we are running about 15 DNB PG courses across Kaveri group of hospitals. So we have around 70 to 100 PGs first year, second year and third years. So every time, whenever the PGs are coming for assessing the patient or to analyze the progress of the patients, the nurses are requested to accompany the doctors, PGs, first year, second year, third year, and the registers, even for the junior consultant and senior consultants. That merely takes the nurses' time almost 2 hours. The nurses are working for 7 hours or 7:30 hours, but about 2 hours, the doctors' rounds, they are taking 2 hours from the nurses' time. Next comes the drip monitoring. Of course, we are giving IV medications, IV fluids for the patients. Almost out of 10 patients, 6 or 7 patients may have this infusions. So every time the nurses may calculate accurately and set the flow rate. But in spite of that, the patient relatives or the bystanders, they used to call the nurses and check the flow. So they have the doubt whether the flow is there or not. It is operated manually. So that problem again comes. So this will also take nurses' time approximately 30 minutes. And the third one is doing the non-clinical activities. Since yesterday we are continuously talking about the non-clinical activities done by the nurses that has to be eliminated as far as it is not in our concern or not in our per se. Okay. So for the non-clinical activities, almost the nurses are spending, we have calculated around 60 minutes during her shift. So these are the problems we have identified. The aim, definitely it will improve the patient care quality by streamlining the routine processes, optimizing the coordination between the nursing and doctor rounds, and implementing the automated IV drip monitoring will definitely reduce the time delay, and thereby it will enhance the nursing operational efficiency. The objectives are streamlining the nursing workflow, improving the efficiency during the doctor's rounds, and automating the IV drip monitoring system. The methodologies. There are few hospitals which are adhering to the 5S and the lean management in the clinical settings. So the Kaveri Hospital is one among the hospitals. We have implemented many initiatives based on the 5S and the lean management in the clinical setups. So here also we have followed the same methodology, the 5S and lean. The one important thing is saving time is one of the most important principle from the 5S and the lean management. One more thing we have analyzed, value-added activities versus non-value added activities. Then process mapping. These are the methodologies we have followed. As we know, this is the daily workflow for the nurses. There are value-added activities and non-value-added activities. In the value-added activities, still the non-value-added activities are also included. For example, during a doctor's rounds is the actually it is a value-added service for the patients. But going for a rounds for about 1 hour, definitely the repetition of the work is also a non-value added activity. So that is we have identified as NVA. Then comes monitoring. Of course, nurses are monitoring different procedures, checking vital signs, everything. But for this IV drip monitoring alone, nurses spending time because of the patient's unawareness and the family unawareness. The third one is the communication. Of course, for the non-clinical activities, so though we have explained to the patients and the patients bystanders, they used to call the nurses for each and everything because they know the person in front of the patient or the family members, always it is nurse. Though the doctor is coming and going, the technicians are coming and going, the other operational people are coming and going, but they have the one person in their thought is always nurses. So they used to call for any activities, they'll first call the nurses. So these are the 3 areas, the non-value added activities are identified. So this is the before and after doctor's rounds efficiency. Previously I told you, the doctors, the PG doctors, the first year, second year, third year, and the junior consultant, registrar, senior consultants. Everybody come for rounds at their time. But here the nurses' time are taking more than what is to be taken care. So in the after process, we have discussed with the HODs of the department, especially with the orthopedics, plastic surgery and the surgical department now. So we have discussed with the HODs and we have escalated the problem, how we are spending time for their rounds. So we have made it mandatory that only the nurse should accompany the HOD of the department, not with the PGs. The PGs can come, they can do the assessment, they can evaluate the patient, and they can document in the documentation record. And if there is a need, they can inform the nurse on the duty or the assigned nurse for any investigations, for any. Again, there was a problem. So the first PG will say something, the second PG will say something, and the registrar will say something. So at last the HOD comes, no, don't do all these things. So again we need to cancel everything. This is again the time waste for the nurses. So that we have discussed with the HODs and they have accepted our problem and they have accepted for single rounds that is done by the HOD of the department. This is one simple, it seems to be simple, but it is very hard to implement because it is related to the doctors. The second one is drip monitoring. So many of us knows nowadays the monitoring is based on the sensor flow. So based on the sensor flow, we can get the alerts and the nurse go and attend immediately, rectify the issues. The third one is, this is important, dial 247. For any activities, the nurse or the patient, they can dial just 247. The nurse, related to the clinical activities, the nurse use this 247. For non-clinical activities, we used to educate our patients at the time of admission itself regarding this 247. Whatever the non-clinical activities related to the maintenance, housekeeping, food and beverages, they can directly dial 247 and they can raise their questions or the inquiries that will be addressed through the supervisor. We have developed our in-house app. This is our app. This is how it works. So by implementing all these 3 initiatives to improve the nursing operational efficiency, we have almost saved 120 minutes to reduced 120 minutes to 20 minutes for the rounds and 30 minutes to 2 minutes for the drip monitoring, and by using for avoiding the non-clinical activities, so we have reduced 60 minutes to 5 minutes. So almost 2 to 2.5 hours the time was saved for the nurses. This will definitely reduce the burnout for the nurses and they can improve their direct patient care services. Definitely a smart workflow design and automation can transform nursing efficiency, allowing nurses to focus on what truly matters, that is direct patient care. Way forward, we are going to have this AI-based tools for improving the nursing efficiency, especially saving the time for the nurses, and they can focus more on the patient care activities. Thank you for the opportunity. Thank you, Annie.
Thank you, Ms. B. Mahalakshmi ma'am, for your presentation. With that, we come to the conclusion of the competition presentations. Before we conclude this segment, I would like to invite Dr. Falakshi Manjrekar ma'am, Director Nursing, PD Hinduja Hospital and Medical Research Center, Mumbai, who would like to share a few words with us. Ma'am? Okay.
A very good morning to all. Congratulations, Annie, especially the Executive Board, our President, Ma'am Ajita, Ma'am Tangam, and the entire Maharashtra group for making this happen. The entire competition was extremely innovative for the simple reason that the jury must have had a tough time to decide that these are the finalists. We were very happy, myself, Dr. Rita Lakhani, and Major Ranjana Williams to be here. Primarily when we spoke about our first issue, the entire concept of coming together, College of Nursing and the clinical service, that itself is an age-old gap which has been prominently existing in the Indian nursing services for the past 100 years or more. Are both presentations by Dr. Dolly Biswas as well as Delphina Gurau brought in excellent strategies. The first strategies was on the principle of mentorship, which is such an innovative idea and very sustainable. I'm sure if we want to implement it, it will go a long way. The second strategy was to use our extremely rich alumni, which I'm sure each and every College of Nursing is very, very proud of, to ask them to come and strategize innovative practices in multifocal as well as multidisciplinary nursing initiatives along with the student nurses. I'm sure the student nurse must have benefited magnanimously. Congratulations for both the presentations. We were very happy to be a part of it, and both of them definitely deserve a round of applause because according to all of us, both of them are definitely winners. We were very happy to see the operational efficiency being presented for nurses. Nurses actually are like, a typical way of describing a nurse is a goddess with 8 hands. At a time, she has to use all her 8 hands and perform 8 activities. Out of that, maybe one of the activity could be nursing. I was very happy to see an extremely innovative project in the administration of daycare chemotherapy project being presented by Poonam Talreja so effectively. A very, very excellent model, and I'm sure it will go a long way if we want to implement it, because these are patients who come to us with cancer, and helping them leave the hospital in a short period of time with a small tatra or performing these innovative activities would go a long way. A very excellent activity initiated by Mahalakshmi, who was innovative enough to initiate an app and decide something which all of us are definitely troubled about. She spoke about IV round, she spoke about doctors, not one doctor, multiple doctors, one nurse, and some excellent innovative practices. I'm sure if we are able to take that forward and pick up a post activity which decreases the nurse's time, increases better nurse satisfaction, and betters patient outcome, what else do we want? Congratulations to all the finalists for presenting some excellent ideas and helping us to take these home, and definitely we are really going to go a long way. Thank you, Annie, for creating this platform. Me, Dr. Rita Lakhani and Major Williams are very happy to be here. Maybe they could like to say a sentence to conclude.
So good afternoon, everyone, and thank you, Annie, the President Annie, and the executive committee members for having all of us here. A wonderful platform indeed. And we as nurse leaders are seated here, and whilst we also seeing, watching our Gen Z, watching them seated here on the stage was a transformation, I feel. And I think so, these two competitions which we face every day, the nursing engagement and the operational efficiency, this has been outstanding. So I congratulate all the 4 speakers over here, and I think so today we have a lot to take away from here. Thank you so much. Thank you.
I think I'll conclude just by saying a big thank you to the Annie team, organizing team, Dr. Ajita, and all of you all over here. Thank you for allowing us to be a jury over here and attending to such wonderful presentations. Thank you.
Thank you, ma'am. We sincerely thank all our finalists for their enthusiastic participation and for sharing their innovative ideas and best practices. Also, heartfelt appreciation also goes to our esteemed jury members. May we give them a big round of applause.
Good afternoon. So let us continue with the competitions. So For the remaining two competitions, I would like to invite the jury members. So calling on stage, Ma'am Shija Kanade, Nursing Superintendent, Narayana Hospital, Narayana Health SRCC Children's Hospital. Huge round of applause, everyone. Dr. Meenakshi Gijere, Head Quality, Symbiosis University Hospital, Member ANEI, and Lieutenant Colonel Amita Naze, CNO, Sri Narayana Institute of Medical Sciences, President, Kerala Chapter, ANEI. So calling on our finalist, for the nurse-led innovations, I would first like to call upon one of my very sincere students, Gayatri Rushikesh More, Nurse Manager, Sir H.N. Reliance Foundation Hospital. Gayatri More. Each contestant will have 7 minutes, after which they will have to stop.
Namaste everyone. Namaste madam. Myself Gayatri Rushikesh More from Sir H.N. Reliance Hospital. I would like to thank Annie for giving me this opportunity to present my innovation. I would also thanks to my organization Sir H.N. Reliance Hospital. So moving forward, my nurse-led innovation is to transform the patient safety and quality of care in critical care unit. So this innovation is based on the transducer holder. So we can see in critical care unit, transducer holder positioning is very important, and it is very crucial task for the nurses because transducer holder positioning is important. Based on that only, the measurements, the vasoactive drugs adjustment has been needed. So this task is very time consuming because we can see nurses are spending huge time on setting up the transducer, and our transducer securement methods are traditional where different organizations are using different techniques, and sometimes we use adhesive dressing material and some cotton tie and etc. So the same inconsistent techniques has been used unit-wise. There is also associated skin injuries that due to repeated use of adhesive taping and all, there is a skin injuries. MARSI has been reported. Infection risks, the thing is that nurses are handling the lines again and again because the transducer is drifting down. So they are trying to readjust. Sometimes it is inaccurate reading as discussed earlier. So we have made certain goals. The goals was to improve the hemodynamics monitoring with the transducer accuracy, stability, reduce the skin injuries associated with adhesive taping, and it also eliminate the nursing time because nurses were consuming the time on the setting of the same. We have certain objectives: patient comfort, standardized securement method across the unit, and enhance patient comfort's mobility because patients are moving from one table to another. Sometimes nurses has to struggle to readjust the transducer, then reduce the infection risk due to line handling, and that's how the innovation has come to develop a simple innovation product. That's how it will help to the nurses. Yes, this innovation has been driven by all the frontline ICU nurses, nursing CNO, Dr. Kavita ma'am, and Miss Indu Elizabeth, nursing education team, infection control team, production team, as well as there was a developer team also involved. So the methodology which we have used, the observation method, as like bedside ICU nurses has reported, there is a MARSI happening due to the repeated use of adhesive taping. Then we have viewed our current transducer workflow, how is the current process and how we can improve. That's how the Easy Hold Grip transducer belt has been started innovation. We have created very low cost and safe material. The pilot test has been done in the ICU in the clinical scenarios. Feedback analysis has been taken repeatedly as and when we are redesigning the transducer belt. We also took some measurement pre and post. The data was collected on the setup time, nurses satisfaction, patient comfort, and the infection control observations as well. So this is the key intervention, Easy Hold Grip transducer belt. So this is portable, single-use product, and this is very soft, skin-friendly for the patient. Here, if we will see, this is very novel product because here we are getting the transducer leveling, cable management, as well as the stability of the transducer also there. So that's how this product innovation is very productive and novel. The outcome and impact which we have achieved the improved patient safety and accuracy. We have saved the nurses' time, so this increases the nursing efficiency, as well as we have enhances the patient comfort. Not only that, but clinical impact also was there. That was like reduced alarm fatigue was also involved, because as the accuracy was there in transducer securement, there was an enhanced patient comfort and mobility. This also impacted as a operational because it is the faster workflow, and this was like less use of consumables like tape, adhesive dressing and all. That's how our fewer interruptions during the transport, as well as our cost saving was there. Per ICU, we can at least save 1 to 2 lakhs per annually. Scalability and replicability. Scalable, as this product is low cost, easily available, and there is a less training is involved. So nurses have been trained and demonstration was been given, and nurses adapted the process very fast. This is replicable everywhere in ICU, OT as well as EMS. Yes, there was certain challenges while doing this innovation. So the coordination and follow-up was required because the team we were working with them, they were non-medical. So we have to tell them what exactly we were wanted and the expected product in the regards to mainly color and the material. Then the design constraints I already spoken. Staff adoption, as many of the people were adopted the previous traditional method, so they were little bit resistant for the adapting this. Procurement and availability. Again, talking with the hospital procurement team and making it as integrating it as a hospital inventory was a great task. Feedback and iteration, there was a continuous follow-up has been taken for the innovation. So the project is demonstrated the power of nurse-led innovation to transform the patient safety and care quality. That's how this is the traditional method which we used to use earlier, and with the help of transducer belt, we have achieved this. So this is the innovation is aligned with the patient safety goals, and this is the creativity of nursing innovation. This innovation proves that if nurses are empowered to solve everyday problems, ultimately the patient safety improves and the healthcare system becomes the more efficient. Thank you. Here I am ending my presentation. Thank you, everyone.
Thank you, Gayatri. I next call upon Suja Kumari S., Assistant Professor, Amrita College of Nursing, Health Sciences Campus, Kochi.
Good afternoon, everyone present here. Today I am standing here to present my nurse innovation project titled Smart Ampule Cutter, a novel device to improve safety in clinical setting. Along with me, 4 fourth-year BSc Nursing students of Amrita College of Nursing were also involved in the study. Moving to the background of the problem, we have searched the literature and found that nurses are exposed to injury by multiple types of sharp objects in their work settings. Nurses are the greater task force in the healthcare settings, and they are exposed to these many issues or challenges, and we are finding a way to find the solution. So while collecting the literature, we found that opening glass ampules causes frequent cuts, exposing healthcare workers to bloodborne infections and work disruption. And we have conducted a qualitative study and an in-depth interview to get user experience from the nurses and nursing students. Along with that, we have conducted a stakeholder survey to understand the need of a novel device to solve the issue. Here, we found that various unsafe methods used to open ampules. In the hospital, they were using bare hands, scissors or sharp objects, or gauzes or cotton. Everything will leads to one or another type of risk of injury, and some of available cutters also not working properly. From the participants' response, we found that whatever available in the hospital is not in precise way, it is not cutting properly. So we are in need of a novel device. Overall, there are some safety concerns, and it is a multi-level problem. Not only for the nursing professionals. For nursing professionals, only the cutting of their finger or injury occurs. But when the cleaning staffs also will be involved while they manage their waste, they will also involve. And another thing is patient safety. Here, due to the contamination of the medication, patient safety also will be disturbed. We have collected from the in-depth interview, we understood that the nurses they are facing some challenges and issues while cutting the ampules. Some of the challenges include injuries, spillage of medication, contamination of medication, and they are exploring that this is time-consuming process. And there are currently available cutters, it is not working smoothly, and especially in the emergency situation, it takes more time to cut the ampule, and it is very difficult to manage the sharp waste. These all findings will lead to our innovation idea, and we named the devices Sniper Ampule Cutter, the introduction of a user-friendly, safe ampule cutter to reduce injuries, contamination, and medication waste. This is a conceptual design of our innovative idea. By starting with our ideation process, we have drawn the 2D design, then progressed to 3D design, and to the development stage. Till the development stage, we didn't get any help from any non-nursing expert. We, along with my students, we have drawn all the dimensions, all the structure, everything. But only during the developmental phase, we got help from the engineering experts, and we have filed the provisional patent after the prototype made. We plan to make 3 stages of prototype, and the first stage of prototype already made. We have compared the available cutters in market, and we found that these are the novel features available for the novel ampule cutter what we are proposed. The first one, ergonomic grip for secure handling and adjustable mechanism for multiple ampule sizes. The currently available cutters, they are not intended for multiple ampule sizes, but what we are proposing, it has all the capability of cutting different types of ampules. And integrated waste collection pouch is there. There is a sharp cutting edge with wide with a safety cover, so it is durable, and there is a durable materials. For example, at the first stage we used PLA, that is polylactic acid, and the second stage we are about to use ABS material, and the third stage we are planning to use stainless steel material for the durability, and it is a compact device. This is the development process from the ideation till the development. Now, this is the impact of the innovation. Here, the preliminary evaluation of the first stage of prototype already completed. Here, it demonstrated improved safety during the stimulated environment. We have tested it, and we got positive feedback from the students as well as the staff nurses. And there is a potential to minimize the injury risk in clinical practice, and we need to further clinically evaluate or validate this device, and we are expecting a metric such as reduction of injury to 80 to 90%, and the decrease in the contamination of the medicine, and the time can be improved to 30%, and the user satisfaction rate also can be increased. And this innovation has some benefits for patients, nurses, and healthcare system. For the patient, there will be reduced risk of contamination of medication, and thus infection will be reduced, and safer medication administration. In those way, the quality of care can be improved. And for nurses, there will be reduction of the injury, and there will be easier and quicker ampule opening, and confidence and comfort of the nurses will be improved, and their physical strain will be reduced. And healthcare system also will be ultimately get benefited by workflow efficiency, and their cost savings also will be improved. Okay. Next, we have learned some lessons, the positives and challenges. Where their positive thing is it's simple and practical design. We got user feedback positively, and there are some challenges. Only challenges we found in the prototype development and limited clinical testing that will be overcome in the next stage. And we are concentrating on the sustainability and scalability of the product by it is a low cost and easy to manufacture, and it can be used in the hospitals and the training institutes, and it can be suitable for a large scale implementation. And key takeaway, important takeaway, it is the ampule cutter is a safe and easily usable, user-friendly design. It can easily adoptable and everything. Or ultimately, what I could say is it is a nurse-led intervention which solves a common problem. I am concluding this. Protecting healthcare and protecting patient. With this quote, I am concluding this presentation. I acknowledge our institution and the Kerala Startup Mission and KDISC. It is an initiative of Government of Kerala for supporting this study by providing all the guidance and the funding opportunity for us to develop the device. Thank you everyone, and thank you Annie. And this is my way of passion to action. Thank you.
Thank you so much, Ms. Suja. Jury members, we now move to the next competition, that is the nurse-led research. And for that, I would first like to call upon Vijay R., Nursing Officer cum Faculty, College of Nursing, Indira Gandhi Medical College and Research Institute, Government of Puducherry Institution, Pondicherry. Mr. Vijay? Yeah.
Before we move on to the next contestant, I have two questions to these two participants. Can we ask questions now?
Yes. Guy. Suja. Can we go with Suja first, ma'am?
Yeah.
Perfect.
Hello, good afternoon. It's excellent device, but I just have one basic question. There are multiple, needle cutters, sorry, not needle cutters, ampule cutters available. So you said that your device is going to prevent infection, spread of infection to the patient. So what is the core difference in your device versus, other devices? And is it that the non-availability of the devices, we are not able to, make the ampule cutters available on the floor? Is it because of that the nurses lead to unsafe practices? What is it that you have, observed?
Thank you for the question. There are similar cutters are available, but the thing is we are using a different diamond technology blade. That is a different thing. So precision cutting can be guaranteed. So no breakage of glass particles. So there is no mixing of glass particles into the medication. So infection and contamination of the medication can be avoided. There is no ampule cutter currently using diamond technology, precise cutting, this blade. This is the main, I have compared this, and that is a peculiar thing.
Okay, thank you. Thank you.
Okay, ma'am, next we go to Gayatri. Ma'am, do you want to ask Gayatri a question?
So Gayatri, Your device is very nice, and I believe it will be very effective and handy to the nurses. Congratulations. However, I personally would like to understand, have you done any study to understand? You have invented the device, but we were not very clear. That's the reason I'm asking you this question. Have you studied, what is the change in terms of statistical analysis of, what is the change after using your device?
Definitely, ma'am. Not statistical, but yes, definitely I have collected the nurses' feedback. And that's how they have rated that before they used to take at least 3 minutes, like bringing the dressing material, maybe retaping, taping, adjustment of transducer on the arm of the patient. But after using this device, immediately it is available. As I already said, we have implemented in ICU as well as EMS and the OT as well. So in these 3 critical areas we have covered. So that is the beneficial for our nurses. Immediately as soon as the patient comes, they do not have to struggle so much for the transducer relabeling and everything.
Okay, thank you.
Moving forward, ma'am, I may go into statistical analysis as well. Because initially I thought this is the innovation, let me start in-house. And as Annie has given this opportunity as a competition, so I got involved. Thank you, ma'am.
Thank you.
Okay. Thank you, Gayatri. Over to you, Vijay. Yeah.
So, good afternoon to everyone. So, special thanks to Annie for giving me this opportunity. Myself, Mr. Vijay, working as a nursing officer cum faculty, College of Nursing, Indira Gandhi Medical College Research Institute, Puducherry. So, along with this journey, I am having my own startup company named Mank Medical Devices Private Limited. And it is currently incubated in SBV MGM Bioincubator as well as Atal Incubation Center, which is located in Pondicherry. So, my problem statement entitled Effectiveness of Disposable Infection-Free Hemostatic Tourniquet on Level of Infection Among Hemodialysis Patients Undergoing Hemodialysis in Selected Hospital, Puducherry. It's a randomized controlled trial study. So coming to introduction, so over 800 million persons are affected by chronic kidney disease and ESRD worldwide and on treatment with hemodialysis. So according to National Institute of Health Report 2024, it stated that chronic renal disease has been acknowledged as a leading health problem worldwide. So as we know, hemodialysis patients are more vulnerable population. They used to frequently get the infections because of their immunocompromised state as well as their unhygienic practices. So traditionally, the simple hemostatic tourniquets made up of the Velcro is used to arrest the bleeding during post-dialysis session. So due to the unhygienic practices and prolonged use of the same reusable tourniquet, result in the atriovenous fistula access site infection. So this study aimed to evaluate the effectiveness of disposable infection-free hemostatic tourniquet, so on level of infection in atriovenous fistula access site among patients undergoing hemodialysis. The stated hypothesis is H1, there is a significant difference in the level of infection in atriovenous fistula access site between patients receiving hemodialysis, those who had been subjected to disposable infection-free hemostatic tourniquet, than those who do not. So about this disposable infection-free hemostatic tourniquet, it's a novel tourniquet invented by me. So it's a non-invasive sterile tourniquet used to address the issue of hemodialysis patient in order to arrest the bleeding during post-dialysis session as well as prevent the infectious complications among hemodialysis patients. So it has 4-layered structure. So all the 4 layers are completely biocompatible and biodegradable. So the outer layer is the microperforated tape, and second layer is the non-woven pad, and third layer is the plantain stem fiber which is extracted from the plantain stem, and the 4th layer is the absorbent gauze with antiseptic gel. In that I used 2% chlorhexidine solution, and the side strap is made up of the loaf of fibers. It's completely plant-based source. So all the layers are stitched together and sterilized with the help of ETO sterilization process. So the core novel thing is, so this is alternative to this tourniquet. This is a Velcro type of tourniquet what patient is routinely getting till now. So it is completely made up of the Velcro and it's a reusable tourniquet. Though it's a reusable tourniquet, it will result in the fistula site infection as well as other fistula associated complications like fistula failure, rebleeding. So this is a completely single-use biodegradable tourniquet. This can address the issue of the patients, especially those who are getting hemodialysis in the tertiary care hospitals. So coming to research methodology, the research approach is quantitative research approach. Research design is randomized control trial, in that I used two-group pre-test, post-test design. And the setting of the study is hemodialysis unit of Mahatma Gandhi Medical College and Research Institute, Puducherry. And the target population includes patients with CKD and ESRD receiving hemodialysis across globe. And sample the patient undergoing hemodialysis via permanent atrial venous fistula access 2 times per week at MGMCRA, Puducherry, who fulfill the inclusion criteria. And the sampling technique is simple random sampling technique. Under that I used lottery method to split the samples into experimental and control group, and sample size is total 60 samples, 30 in each group, and randomization was done 30 in experimental group and 30 in control group, whereas the participants in the experimental group pre-test was collected under pre-test. I have collected the socio-demographic variables, clinical variables, and the level of infection was assessed by using the Sen-Helios scoring system. It's a standardized tool to assess the level of infection among hemodialysis patients, especially over the fistula site. And intervention was done in pre-test, in experimental group participants. They have applied the my tourniquet. It is disposable infection hemostatic tourniquet during post-dialysis session to arrest the bleeding for a 1 month period. And whereas in control group participants, they were in the routine care, they are using the gauze piece to arrest the bleeding, and with the help of this Velcro type of tourniquet to compress the fistula site. So after 1 month intervention period, post-test was conducted to check the effectiveness of disposable infection-free hemostatic tourniquet, and data analysis and findings and results was done. So coming to criteria for sample selection, inclusion criteria, that includes the study include the patients, both male and female, diagnosed to have chronic kidney disease ESRD and undergoing hemodialysis via permanent atrial venous fistula access, receiving hemodialysis 2 times per week at MGMCRA, Puducherry. Exclusion criteria, it includes patients who are undergoing hemodialysis via catheter-based interventions such as intrajugular venous catheterization and perm cath and femoral cath type of vascular access, and those who are not interested to participate in the study and who are critically ill, having altered sensorium, who are having history of systemic infection, diagnosed to have valvular and bleeding disorders such as coagulopathy, and patient having recent arteriovenous fistula angioplasty. So about data collection procedure and methods. So after obtaining the permission from the authority and IHEC members of SBV, Sri Balaji Vithi deemed to be university, the data collection was done from 2/5/2024 to 10/6/2024. A total of 60 participants were selected by simple random sampling technique from the hemodialysis unit of MGMCRA, Puducherry. Informed consent was obtained from all the study participants. Pre-test demographic and clinical variables were collected by interview method. Level of infection in atrial venous fistula access site was assessed by using this structured observation checklist called Sen-Helios scoring system for hemodialysis exit site. DIFT was applied to the experimental group participants, whereas in control group participants were in routine care, using the gauze piece to arrest the bleeding. And post-test was done after 1 month intervention. So this is about the tool description. Part A includes socio-demographic questionnaires, and Part B clinical variables. Part C, so Sen-Helios scoring system to assess the level of infection in atrial venous fistula access site among hemodialysis patients. So this is about the tool Sen-Helios scoring system. It has following parameters include redness, swelling, pain, exudate, pus. So based upon the score, the participants were classified. So if the participant score is more than 4, they comes under the severe infection, 2 to 3 mild to moderate infection, 0 to 1 mild infection category. So plan for data analysis. So descriptive statistics include frequency, percentage distribution, mean, median, and standard deviation. So inferential statistics, I used Wilcoxon sign rank test for within group comparison and man witness test for between group comparison. So coming to result, so this part shows the level of infection in intravenous fistula access among patients undergoing hemodialysis. So during pre-test, majority of participants, they were in the category of mild to moderate infection. After the intervention, post-test shows that many of the people were drastically shifted from mild to moderate category to no to mild category. That's a great highlight of this study. And coming to the evaluate the effectiveness of DIFT on level of infection. So in experimental group participants, the pre-test mean score is 2.27, median is 2, and standard deviation score is 0.74. And the post-test score is 0.57 and median score is 0 and standard deviation is 0.73. The obtained Wilcoxon sign rank test value is 4.893 and the p-value is 0.001, which shows a highly statistically significant difference between the pre-test and post-test score in experimental group participants, whereas in control group, pre-test score is 2.17, median 2 and standard deviation is 0.75 and post-test 1.82 and 0.81. The obtained Wilcoxon sign rank test value is 2.129 and the p-value is 0.033. So this is the visual guide. So this is what is spatially routing. Patient is routinely getting the like hemostatic option to control the bleeding during post-dialysis session. It is completely made up of the Velcro. There is no specific layers of, present in this tourniquet, whereas my tourniquet is comprised of the 4 layered structure, each having the property to arrest the bleeding as well as prevent the infection. So this is status before and after implementation. To conclude, so this disposable infection-free hemostatic tourniquet created a valid response among the hemodialysis patients, those who are getting the dialysis treatment through atrial fistula access. So last year I started the startup initiative called the Mank Medical Devices Private Limited. It's a faculty startup which is currently incubated in the SBB MGM Bio Incubator. And last year I got an award from IGNO University for Best Startup Award. So I am the one who got the Startup TN card from the Tamil Nadu government to leading forward this startup into the next level. Thank you so much. Any doubts?
Hello. Great presentation. Just want to ask you regarding the tourniquet, what you are telling. The 4 layers you were telling, any specific gel or anything is used inside, or how the blood get absorbs? What is the technique you are used?
Actually, I am using the 2% chlorhexidine solution. It acts as an antiseptic gel. It acts as an antiseptic property as well as it arrests the bleeding at the earliest. So the normal duration of arrest the bleeding is usually 8 to 10 hours, whereas this tourniquet attain the hemostasis between 2 to 4 hours. So it gives the firm compression over the fistula site so that the bleeding duration can be limited.
See, chlorhexidine, what you are using, it is an antiseptic
It is
solution,
an antiseptic solution.
no doubt about it.
Yes, ma'am.
A disinfectant rather. I'm not aware of any property where, chlorhexidine can aid in controlling bleeding.
No, this chlorhexidine is only inhibit the entry of pathogens to the decontamination site. So the four mentioned layer only arrest the bleeding at the earliest.
Okay.
Because it provides a firm compression over the fistula site so that the bleeding duration can be reduced.
Fine. And one question regarding your methodology. You have used, study, it's an experimental study, very good design. But your inclusion and exclusion criteria does not, explicitly talk about the comorbidities that the patients who are with hemodialysis have. Usually, most of the patients may have diabetes and other comorbidities. Have you taken that into consideration? That is number 1. And the number of dialysis cycles prior to your intervention. Was there anything, any control on these 2 factors? Because they can definitely have a, good impact on number of infections that the patient can get. So maybe when you are expanding your study further, you can take this into consideration. And second thing is, what are the other factors which definitely, affect infections? Even those need to be taken into consideration. It's not just the bleeding alone, which will, have a big impact on infections. Thank you.
One thing I wanted to understand, these are our chronic patients. So this tourniquet is going to be used in one cycle. How many cycles do you think you are able to use one tourniquet?
This is single-use tourniquet, ma'am.
Yeah, that's what, when it is a single, it's a disposable thing. So how cost effective it would be for these chronic
the manufacturing
patients?
cost is only 3 to 5 rupees.
That's the manufacturing cost.
Yes.
So when it lands to our patients?
Almost 7 to 10 rupees.
Thank you.
And one more add-on point. So currently we are doing the project in large scale. For this project, NRDC funding us rupees 2,65,000 for doing this project in large scale. Thank you so much.
Thank you, Vijay. I would now like to call a young, vibrant nurse, Tushar Singh, MSc Nursing second year, Holy Family College of Nursing, University of Delhi.
Thank you so much, sir. I would like to start with an opening statement. Patient safety is not built with only at the bedside. It is built in every handover, every conversation, and every transition of care. While treatments and technologies heal patients, it is accurate communication between nurses that protects them. When communication is strengthened, patient safety is strengthened too. So with this, my study title is a quantitative study to evaluate the effectiveness of an ISBA structured AI-powered voice-to-text solution in terms of quality, completeness, and efficiency of nursing handover documentation among the ICU nurses. With my mentors, Professor Dr. Raminder Kalra and Ms. Tenzin Wasser, Assistant Professor, Holy Family College of Nursing. So, effective communication during nursing handover is a critical component of patient safety, especially in the ICU settings with traditional handover techniques which are very much time-consuming, unstructured, and prone to information loss. So with the review of literature and the qualitative phase of the study, we have framed the aim of the study to develop and evaluate the effectiveness of an ISBA structured AI-powered voice-to-text solution for the same quality, completeness, and efficiency and knowledge and user acceptance of the nursing handover documentation among the ICU nurses, with a primary objective to determine the effectiveness of the app, along with the secondary objective to evaluate the effectiveness of the PTP on AI-powered ISBA voice-to-text solution in terms of gain and knowledge with demonstration. Second is to assess the level of satisfaction and acceptance of ICU nurses towards the AI-powered ISBA voice-to-text application. With the research approach is quantitative research approach. Design is quasi-experimental, pre-test, post-test, control group design. Research setting is ICU of Holy Family Hospital, New Delhi. Population registered nurses working in ICU. Sample ICU nurses who met the inclusion criteria and were available during the period of data collection. Sample size 60 ICU nurses, which are being divided into two categories. Experimental group 30 ICU nurses with the AI-powered voice-to-text solution and 30 in the control group with the following conventional handover documentation practices. With technique of simple random sampling lottery method, variables, independent ISBA structured voice-to-text solution, whereas along with PTP and independent we have knowledge, quality of handover, completeness of handover and satisfaction and acceptance level of nurses. Next one we have the criteria. Inclusion involves a minimum 6 months of ICU experience, directly involved in patient handover and willing to participate in the study. Exclusion, not available. Nurses, those who are not available during the data collection. Data collection tools involves the development of ISBA structured AI-powered voice-to-text solution. Demographic performer, standard structured knowledge questionnaire, planned teaching program, ISBA checklist for completeness, and the standardized tool to assess the quality, that is handover evaluation scale, along with the satisfaction and acceptance survey. Along with this, we have the data collection procedure in the terms of symbolic representation, in which the nurses are being divided on the two groups, experimental and control group, whereas on the day of pre-test, day 1, we have conducted the knowledge. For both the groups, we have assessed the pre-test assessment of the knowledge and the handover evaluation scale, that is the quality. After that, we have started with the intervention, that is being represented with A2, A1, A2, A3, and A4, that is a regular use of the app, along with I2, I3, I4, and I5 are being the regular conventional methods of the practices of handover which is being done by the nurses. Then on day 7, we have conducted the post-test assessment of the knowledge, quality of handover, along with the completeness of the handover and the satisfaction in the experimental group and the regular practice of the control group. Next one, the results shows that there is a in the age there is a majority of the nurses belongs to the category where 25 to 44 years old, whereas in education qualification, most participants holds a diploma in nursing with 73.3% in experimental and 66.7% in control. Whereas in the category of ICU experience, majority had 1 to 3 years of ICU experience. In the experimental group with a percentage of 46.7%, and the control group has more nurses with more than 3 years of experience, that is 43.3%. In the terms of knowledge, we have a significant improvement in the terms of knowledge in both the pre-test categories and the post-test categories of both the control group and the experimental group, whereas the frequency, the highest frequency in the categories of pre-test and experimental group is 22. In the post-test, it reached to 21 in the category of good knowledge. Then we have the findings which are related to the completeness of the ISBAR checklist. ISBAR stands for Introduction, Situation, Background Assessment and the Recommendation, which supports the IPSG goal number 2, that is use effective communication, in which we have seen through the table there is a significant increase in the mean difference on day wise, which is being replicated, or it is being shown properly through a line graph where the green line shows the experimental group that has a significant rise in the mean scores by using the ISBAR structured AI tool, which leads to the improvement in the checklist and the completion of the handover. Then we have the comparison of the within groups and the between groups effective size using the Cohen's D, which shows that there has been extremely large effective intervention is being used of the AI, majorly in the experimental group as compared to the control group, with the Cohen's D value of 2.38. That shows extremely large. Whereas in the terms of satisfaction survey, the maximum frequency reaches to the high acceptance, that is 16, in the category of high acceptance by the nurses. In the topic of discussion, we say AI-powered ISBAR significantly improved knowledge, completeness, quality, efficiency, and satisfaction among the experimental group, whereas there are different researchers which supports ISBAR and digital tools. Present study shows that there are stronger outcomes with the AI integration. Then when we talk about the conclusion, in conclusion, I would like to say AI-powered ISBAR voice-to-text application significantly improved nursing handover practices in ICU. Knowledge scores has been increased significantly after the intervention. Completeness and accuracy of documentation improved with continuous rise in the ISBAR checklist scores. Along with this, it helps to achieve high-quality handover post-intervention. Very large effective size confirms strong effectiveness of the intervention. High satisfaction and acceptance reported related to the AI-powered tool. Along with this, my intervention aligns with IPSG goal number 2, that is use effective communication, and the intervention is being proved to be time-saving, efficient, and user-friendly with nurses, demonstrating good readiness to adopt it. It is recommended for integration into routine practice, aligned with HIMS to enhance workflow, patient safety, and quality of care. Currently in the ICUs, not only in the ICU as well as in the other areas of the Holy Family Hospital, it is being used, and it is being used in a routine practice of the nurse's handover, and the significant reduction of the handover from 40 to 45 minutes of the nurses is being reduced with the help of the app to 2 minutes to 30 seconds with a generated report in the form of ISBAR. If the jury members and the organizers allows, I would like to show the checklist, how my app providing the checklist and promoting patient safety. So this is the format of the checklist, which is being produced in the form of the same ISBAR structure standard. That is, it goes with the patient overview, a basic introduction about the patient. Then it goes with the identification part of the patient. Then it moves to the situation, which involves diagnosis, current medications, ongoing treatment. Then we have the next part, that is the background assessment, background assessment recommendation along with the vital signs comparison table. And lastly, it provides a compliance too with the checklist scores out of 31 or out of 30, how much the nurse will be, like after giving the handover with the app, it will show the compliance, whether she has given or whether she has fulfilled all the components of the ISBAR or not. After this, it provides the priority score for the patient, whether it is high and what all action items are needed to be taken care in the next shift. Thank you so much.
Just want to ask one question, that is this project adaptable for a low resource setting hospital?
Yes, ma'am.
How?
Because it is just not only being required a very large effective devices, it can be normally, the app can normally be worked upon our normal internet as well. Like we have, this app was integrated in Holy Family Hospital by using the 5 basic mobile phones with the hospital SIMs in it, just to prevent the patient data and data security of the patients. It is being used in the normal mobile phones as well. It is being compatible with all the Android databases. It is not required any particular sort of update which is being required in the mobile phones.
No, my question is that it should be purchased by the hospital, right?
No, so this can be prepared by the hospital itself as well, by the IT department. It does not need it to be purchased.
But the hospital has to invest into it.
Yes, ma'am. Like some of the amount, not some of the amount, as every hospital has their IT departments. All the software systems which are being working there, like every hospital has HIMS. So through that, it can be easily being developed.
Can there be an interface with our HMS?
Yes, ma'am. It
Because-
can be easily integrated with the HIMS.
So that would be like, and if there are, if you are using your EMRs and if it's online, so all those documentations, whatever the nurses' assessments are there, can that be interfaced?
With this,
Yeah.
definitely yes, ma'am. It can be done.
So as you mentioned, the nurse has an opportunity to have reduced in her handover, shift, and the communication is improved. So if these, the data or the document assessment or your medication management, if all that is getting interfaced, and can that be, it comes as a review also for the next shift nurses.
Yes, ma'am.
So that can be established, or
This is already being established, ma'am. Once the nurses during a particular shift gives their handover, the handover checklist comes to the nurse in charge over there in that particular shift. Before sending them, before ending their shift, he or she reviews every handover which is being done by the scores which are being given by the compliance checklist, and what all the action items which are being included in that, and then accordingly they are being dealt to the other next shift nurses.
one more thing I would like to understand, is it only ISBAR which is designed, or if I want something, an option like an open text, like of course it's,
Yes, ma'am.
so that is available.
It can be available in the open text form as well, but we go for a standardized documentation. So as per
along with the standardized
yeah,
ISBAR.
along with yes, ma'am. Along with standardized documentation, if you want an open text information related to the handover, that is also being generated in an elaborated way.
Okay, thank you.
Now, since you are presenting a research, okay, I just have one ethical consideration. The patients on whom you have used this particular voice to text application, have you taken their consent?
We have taken the consent from both the nurses and the patients as well.
Nurses as well as patients, okay.
Yes, because
And-
mainly the nurses were involved during the handover process, but we do
But
have
it is
taken.
patients' data.
Yes, but we have taken the consent from the patients as well. We have clearly taken a written consent form, which was being there and signed by the patients or the patient relatives related to the
But in
same thing.
ICU, maybe the patients have not,
That's
are
why,
not in a
yes, ma'am.
position to
For
sign.
them, we have taken the relatives' data, relatives'
Okay.
consent.
And I just want you to little bit elaborate on data security.
Okay. So for the data security, what we have done, we have not been given this app to the nurses to use. We have taken 5 mobile phones, the basic mobile phones we have purchased from the market, which is being ranging into the category of rupees 5,000 to 7,000. We have taken that phones and we have incorporated the app directly into those phones, and every hospital has some certain SIM numbers which are being given to the officials for the use. So we have used the same SIMs which can be applied for the internet availability in those mobile phones, and we have used the app in those mobile phones, which has been there during the ICU settings only and has been handed over to the each nurse in charge or to the TL of the particular shift.
Okay, thank you.
Thank you so much.
One thing I just need clarification. 2 nurses, when they gives handover, the voice is recorded with your app and it is getting texted.
Yes, ma'am.
Okay, so where the text is reflected?
The text is being reflected in the same app, and the text comes in this in the form of the report which was being just now presented.
Where it comes?
In the mobile phone, or in the desktop, which is being available in the particular area of the hospital. There you can take a printout of it, or if you want to use it just on a soft copy basis, we
So
can.
the nurse to nurse handover of ISBAR format, every details which is getting recorded and then it transcribed, and from every time we have to take the printout,
And we
every
keep it in the
sheet,
patient.
and the printout will go inside the file of the patient.
Yes.
That is the thing.
And it is being signed by the nurse who has given the handover and the nurse who has taken the handover. The report is being signed by them as well.
Well, so nurses are documenting as well, might be having so many other formats to document, intake output chart and this and that. So all those are there.
Yes, ma'am. Everything is there into the ISBAR format itself.
Only the communications, handing over process have been documented in ISBAR format.
Yes, ma'am.
And that is getting, that printout you have to file, you are filing it up after
Yes.
signature.
Yeah.
Understood. Thank you.
Thank you.
I have a question, quick one. So, since it is a nurse-to-nurse handover, what is the indication or requirement of taking the consent from the patient?
Because, ma'am, while giving the handover, we are taking the patient's while giving the handover, we are dealing with the patient data only. At that time, it is needed for us. For my study, it was being needed at that time to take the consent from the patients as well, or from the patient relatives, that we are going to use your patient data to test my app, or to check, or to test, or to use this particular data of a patient during my research study.
As a part of research
Yeah,
study.
yeah. Thank you so much.
Basically, this is a test mode, where we are using patients' data for handover. So under DPDP Act, we need to, take patients' consent because it's still not in use in HMIS, not integrated. So data security also needs to be taken into consideration. Yeah.
Thank you, jury members. I would now like to move to the photo corner.